Hey guys, it's Andreas here, and welcome to my Study With Me session. Today we'll be studying for about 2 hours, right? And before we begin, just want to give you guys some pointers. Make sure you guys got a cup of water, go to the bathroom, make sure you're not hungry, right? I wrote down some things over here. Make sure you have a list, so you're not just studying aimlessly. So I have a list today, so I'm going to start off with review, what I learned a couple of days ago, and just to keep it fresh. Then I'm going to go over chapters 7, 8, and 9. I know it sounds like a lot, but these chapters in this book I'm doing today, which is called Pistana Surgery Notes, they're pretty short chapters, so I'm not really worried about that. Then after that, I'm going to do questions to just enforce what I've learned. I added a couple of things that you can see, a fireplace to relax us, and also I added a timer. This timer is that 25 minutes on, 25 minutes on, 25 minutes where you work, and then 5 minutes you have a break. I think they call it Pomodoro. But you know me, I just work straight through. I don't look at the clock because at the end of the day, if you want to buy things without looking at the price tag, you got to work without looking at the clock. So that's my philosophy. So let's get into it, all right? So serum hemoglobin plus 3, and then transferrin plus 1, right? The 3's right. Good. Now, when you have a diabetic coma, that's going to be after complication. Now, diabetic coma, now the management, you want to do rehydration therapy, right? And then you want to correct the hyperglycemia and acidosis. But in the presence of sepsis, let's say you're getting a surgery because of sepsis, you really can't fix the hyperglycemia or sepsis without first while you have sepsis. And then also you want to correct the urinary output. Good. Okay. Now, traumatic rupture of the diaphragm. So when you have traumatic rupture of the diaphragm, how does this occur? And then you have, so when you have traumatic rupture of the diaphragm, what happens here is that you're going to have something known as what? How do you have traumatic rupture? Your diaphragm ruptures how? Okay. Now, traumatic rupture transition to the aorta. Now, it's going to occur at the bifurcation between the artery of the aorta and descending aorta, right? And how does it occur? It occurs when you break like a bone that's hard to break, like the sternum, the scapula, first rib, or you have a wide mediastinum suspected. And this is gonna come about when you have deceleration injuries, like a car crash where you come to a sudden stop, and you're usually asymptomatic until this hematoma within the adventio ruptures and the patient dies. You're gonna diagnose it via your I think you're gonna use your diagnosis via echocardiogram EKGs, and also you can diagnose it via your troponin levels. Good. Now, traumatic rupture of the diaphragm, how does that occur here? When you have a sudden, like I think you have chest trauma, right? And if you have signs, and you can have free air in the diaphragm. Let me see how that happens. Now, let me go back to that. How did I forget that? Page 10. So again, no, I fucking messed it up. So in order to diagnose your traumatic rupture of the aorta, you're going to do in like non-traumatic, you can use in traumatic centers, you can use spiral CT angiograph or spiral CT. Then you're going to use MRI, transesophageal echocardiogram or transesophageal echocardiogram, or spiral CT angiograph, right? Now when you have a traumatic rupture of the diaphragm, what happens here is that you're going to have bowel that shows up. You're gonna see it, right? It's gonna be on physical exam or X-ray. You're gonna see bowel on the left side of the chest, and then you're gonna diagnose it via laparotomy, which is gonna be like a abdominal laparoscopy, right? And then the treatment here is gonna be surgery via the abdomen. I'll do that soon. Now, following case of the postoperative fevers. Now, when you have a UTI, you're gonna have a post-op fever on day 3. You're gonna do urinalysis, urine culture, and then treat with the empirical antibiotics. Now, DVTs. Now, the signs over here, you're going to do CT of the pelvic veins as well as the pelvic veins, right, and the veins of the lower extremity. Good. And you're going to have a DVTs. You're usually going to develop a postoperative fever 5 days following, and treatment is going to be anticoagulants, right? Or you're going to start off with heparin and then bridge over to warfarin. Good. How? And you can do a duplex, right? So Doppler's going to diagnose it. We'll have day 5. Yeah, so diagnostic modality. Good. Doppler studies. Good. Okay. Now, obstructive jaundice caused by a tumor. So this is going to be malignant type of jaundice, right? Now, key features when you have obstructive jaundice is that you're going to see, when you do your ultrasound, you're going to see a gallbladder, right? That's going to be what? Thin-walled, distended, large gallbladder, right? So it's going to be distended and large. And the types of cancers, you can have your ampullary cancer, you can have your adenocarcinoma of the ampulla, all right, adenocarcinoma of the head of the pancreas, and cholangiocarcinoma of the common bile duct itself. Is that correct? Good. Now, when you look at the signs you're going to have, is that if you have a large pancreatic cancer, which can be seen by a CT, which can confirm that, you're going to have weight loss as well as chronic back pain. Good. Then if your CT is negative or you have none of these symptoms, then what are you going to do? Then you can do your magnetic resonance cholangiopancreatogram, right, which is going to detect smaller cancers like cholangiocarcinomas, neoplasms, right, and adenocarcinomas of the ampullas. Got it? Now. How you can do the biopsies. So if you have a large pancreatic tumor, you're going to do what? For that one, you're going to do a CT guided percutaneous CT biopsy, right? Then what about for your? Then you have endoscopic retrograde cholangiopancreatic plus brushing for your ductal neoplasms, right? You're going to have your endoscopic ultrasound for your small tumors of the head of the pancreas, right? Tiny tumors within the head of the pancreas. And you're going to have endoscopically for your ampullary cancers. Good. Right? For ampullary cancers. Good. Pretty good, right? Okay. Now, majorlan ulcer. Now, majorlan ulcer, what happens here is that this is going to be where you have squamous cell carcinoma developing within an ulcer of the leg, right? And and usually it's going to develop in like an ulcer that's been there for a long time, and it's usually going to be in the presence where you have healing and like the breakdown and healing constantly occurring. This happens in the setting of like a third-degree burn that is healed by itself, or continuously draining sinus to secondary osteomyelitis, I believe. And then how to diagnose here is I think you're going to do like a biopsy for this one, right? And then the treatment for these is going to be, depends, a skin biopsy. And the treatment is going to be, you're going to use skin grafts, plus you're going to use also excision. Good. I get that right. So, concept of they're classified many years of healing breakdowns. So there's untreated third-degree burns, spontaneous healing, and chronic drainage. Okay, good. Now it's going to look very dirty, so I forgot to put that in there. How's it look? Another hockey add-on. Dirty looking deep ulcer. Dirty looking deep ulcer with heaped up tissue around the edges. Heaped up tissue around the edges. So it's a dirty looking ulcer with heaped up tissue around the edges. Good. Okay. Now, when you have a scaphoid fracture, we have your carpal and navicular, right? And it's going to be where a teen's going to fall in an outstretched hand, and you're going to have tenderness over the wrist and over the anatomical snuff box over here. And what happens here, snuff box, right? And you're going to do an X-ray, and that's what's going to show here, and that's what's going to show. Right, an X-ray, and usually if the X-ray comes back clean, what you're going to do here is that you're going to put a splint, I guess, right? So a splint, and then repeat the X-ray in about 3 weeks. But if the initial X-ray shows a fracture, then you're going to need open reduction. You need open reduction, internal fixation. Good. That's true. And then complications is that you have to watch out for compartment syndrome, I guess, right? No, scaphoid. When you have a scaphoid, you might not get non-reunion. That's what's going to happen. Non-reunion. Good. So carpal adults, and then you complain of wrist pain, right? Good. And then X-ray show usually negative, and then Spicocast, so thumb Spicocast. Okay, good. Okay, fracture, open sign for non-union. Good. Now, what about your metacarpal neck fractures? So metacarpal neck fractures over here, this occurs when a closed fist hits a wall when you punch something, right? You're just going to be in the third or fourth metacarpal, or the fourth or fifth metacarpal, or even both. And okay, and signs over here is that you're gonna have swelling and tenderness, overpalpation of the affected metacarpal. And how to diagnose here is just gonna show you're gonna just do an X-ray, is gonna be diagnostic. You can just use a ulnar splint if it's like you treat it based on the degree of like how bad it is. A wire and Kirschner and wire plate fixation for bad ones, and then ulnar gutter splint for a close reduction gutter splint. Good. So ulnar gutter splint. Good. Now, acute ascending cholangitis, right? Now, when you have acute ascending cholangitis, so we have cholecystitis, which is infection of the actual like gallbladder, but the biliary tree is going to be acute ascending cholangitis, which is going to be very, very deadly. In terms of what happens here is that the gallstones, right, are going to go from the cystic duct and actually occlude they reach the common hepatic duct, right? And you're going to have a partial obstruction of bile flow, and you're going to have an ascending infection, which makes your central nervous system sometimes like a coma. Good. Now, when you have ascending cholangitis, you're going to have increased, I forgot what happens here. So, okay, reach the common bile duct, right? No, the common duct. So common hepatic, we have the common bile duct, not the common duct. So reaching the common duct or common bile duct, right? So we have the cystic duct and the pink, and common, okay, that makes no sense, right? Reach the common bile duct over here, and you have a partial obstruction and ascending infection. Now patients are usually going to be, the patients are going to look older and sicker, and temperature is going to be 104 degrees to 105, fever and chills, and very high white blood cell count, indicating of sepsis. Good. So you're going to be an older patient who's very sick, fever 104, 105 degrees, and very high white blood cell count, which indicated of sepsis. And they have hyperbilirubinemia, both conjugated and unconjugated, and they're going to have also elevated alkaline phosphatase as well, extreme high phosphatase. Now, then we need IV antibiotics and immediate decompensation of the common bile duct, right? Ideally, you can do it by endoscopic retrograde cholangiopancreatogram. Alternatively, you can do percutaneous with a percutaneous transhepatic cholangiogram, or rarely you can do surgery. Then eventually, cholecystectomy is going to be required. So, indications. What happens is that the cystic duct that's obstructed by a gallstone, it's going to be removed, and it's going to be include a partial obstruction in the common bile duct, which is going to lead to an end-setting infection. Good. Now, signs over here is that usually going to be like older person, usually going to be a very more sick-looking patient, right? And they're going to have a fever, 104, 105 degrees. They're going to have chills as well. They're going to have white blood cell count. It's going to be very, very elevated, indicative of sepsis. On top of that, hyperbilirubinemia. Then also they're going to have very high levels of alkaline phosphatase. Now, that's the labs. Treatment for these ones, IV antibiotics and immediate decompensation of the common bile duct. So you do that by the endoscopic retrograde cholangiopancreatogram. But if you cannot do that, you can also do surgery, or you can do the second best option is going to be your percutaneous transhepatic cholangiogram. Then following that, you can always do elective cholecystectomy to remove the gallbladder. Obstructive jaundice is that instead of having a partial obstruction, you now have a complete obstruction of the common bile duct, and all right, and this is without ascending cholangitis. And presentation management, and then what's the presentation of obstructive jaundice is that in any case you're going to have increased unconjugated bilirubin and conjugated bilirubin, so hyperbilirubinemia. You're going to have moderately elevated AST, ALT, which are transaminases, and really, really high levels of alkaline phosphatase. And to manage this one, for obstructive jaundice, first you're going to do an ultrasound to assess to see if the biliary ducts are occluded or are dilated, and also get to like a point as to what's the cause, right? And then from there you're going to treat it accordingly. Usually you're going to do an endoscopic retrograde cholangiopancreatogram plus a sphincterotomy to remove the stone, and then followed by cholecystectomy. Good. Is that true? Let me see. So, whatever, we got that right, but we're going to do it again anyway. Okay, acute pancreatitis. We did this one, the first one we did. You should suspect an alcoholic who develops upper abdomen acute abdomen. So pain in the upper abdomen, good. And pain is going to be constant pain, right? It's going to radiate right. It's going to be constant. It's going to radiate right to the back. And you're going to have rapid onset of inflammatory signs as well. You're also going to have nausea, vomiting, and retching. And remember, in pancreatitis, you have no systemic signs, no fever, and no leukocytosis. how to diagnose it, if you look at your serum or urinary amylase and lipase levels, if you look at the serum ones between 14 and between 12 and 48 hours. If you look at your urinaries, it's going to be between the 3rd and 4th day. Treatment for this one is going to be nothing per oral, nothing per oral, right? You're also going to use IV fluids and nasogastric suction. Good. I want you to get 15 minutes. Good. Now, intraoperative tension pneumothorax, right? So how this develops is that this is going to be seeing someone who has multiple abdominal traumas or multiple trauma wounds, right? And when you go to suture the tissue back, because they receive multiple amounts of fluids and multiple blood transfusions, the tissue is going to be too tense to actually like sew up, right? And you cannot sew it up. And this can also develop 2 days postoperatively. And when they come in, we'll talk about that. But basically, what's going to happen is that you have like sutures or stitches going through the tissue. You're going to have you're going to be hypotensive, right? You're also going to be hypotensive. And what you need to do is you need to open up the wound again and then reschedule surgery for a better date. But in that case, you want to stop whatever you're doing, stop the laparotomy, right? And then cover the wound and pack the wound with either like a mesh that's absorbable or soluble or like some plastic, and then resume surgery when possible. Good. Then let me see. I kind of forgot who develops them, but I know how it works. Intraoperative tension pneumothorax, right? Not coagulopathy. Intraoperative tension pneumothorax, right? This can develop where you're going to have some sort of so this is going to be a patient who has recently traumatized lungs, so who has patient with traumatized lungs, so recent blunt trauma or like with blunt trauma to like the chest with punctures by broken ribs, and once the lungs are exposed to positive airway pressure, good. They're going to get difficulty to ventilate, right? Difficulty to ventilate, and you're going to have a drop in blood pressure, but an increase in your central gauge pressure. Good. If the abdomen is open, right? You can do rapid decompensation from the diaphragm, but if it's not open, then you can insert a chest tube into the anterior and upper lobe, right? Then put it into a closed water container, underwater container. Good. Fuck it up again. Okay. Now, we have here. So traumatic rupture of the diaphragm, we saw how this occurs. So the signs of this is going to be traumatic rupture, how does it occur, and then treatment for these. So we keep forgetting this, but in order to when you have traumatic rupture of the diaphragm, if you have the signs, how to diagnose and all these treatment. I think I have it wrong over here. So the sign of traumatic rupture of the diaphragm is when you have bowel located on physical exam or X-ray on the left side of the chest, and you're going to diagnose it by laparotomy, surgical excision. And then if you treat it, you have to do abdominal surgery. Good. Traumatic rupture, the diagnosis, you're going to do a non-traumatic setting, a CT angiograph, which is CT spiral, MRI, or you can do a transesophageal echocardiogram, but in traumatic setting, you do CT angiograph. Good. Now, other aspects to treating burns besides fluids. First off, you want to do pain management. Early on, what you want to do here is the IV. You want to do IV pains. Medication is good. Then you want to give a tetanus shot and also clean the wound. You want to do nutritional support, which is going to be a high-calorie diet, high-nitrogen diet as well, via the gut tubes, right? And then also you want to do some topical silver sulfadiazine. And then if you have a deep penetrating wound, you're going to use your mafenide acetate, but only use it for deep wounds because it's going to cause pain to the patient. It might cause acidosis as well. And what else do you have? You have the pain medications. We have the pain. That's one. We have the nutritional support. And then if the wound does not heal by day 2 to 3, make sure you have weeks 2 to 3. You have to do a skin graft. Yeah, skin graft's required. Yeah, mafenide. Good. Okay. Now, epithelial tumors and adenomas. So epithelial tumors and adenomas, they can metastasize either by the lymph or either by the blood, but it depends on what cancer you're talking about. Breast cancers, epithelial breast cancers, adenocarcinomas in the breast, they like to travel hematogenously to the other beats, to the bones and the brain. While your liver cancer, or what is it going to be? Your lung cancers, I believe, they love to go to the bone. And your sarcomas, right? Your liver cancers love to go to the bone, I guess, right? And your sarcomas love to go travel to the lungs. Good. So liver likes to go to the bone, and the sarcomas like to travel to the lungs. I believe. Let me see if is that true. So So if it's either empty, okay, good. Now breast, and then in the liver, they like to go to the bone. Yeah, abdominal, no, I fucked it up. So breast cancers favor the bones rather than the brain, while abdominal adenocarcinomas like to go to the liver, while sarcomas, they ignore the lymph, sarcomas, they love to go to the lungs. Good. Now your abdominal adenocarcinomas like to go to the liver. Good. Now chemotherapy, so treatment of cancers. So cancers are generally labeled as curable. If they're isolated for one spot, you can cure them by either resection or you can do radiation. When they become palliative, which you can only reduce the symptoms, is when they metastasize, right? That's just going to be the blood or lymph, and then from there, all you can really do is chemotherapy, and on some, you can do hormonal manipulation. Now, chemotherapy, they're going to target rapidly dividing cells, but the only side effect is that they're going to destroy hair follicles, the internal layer of the gut, and also bone marrow. And other complications are specific to chemotherapy, like your adriamycin, that's going to cause you to have that's going to affect your myocardium. Your bleomycin, that's going to cause you to have pulmonary fibrosis. Your cyclophosphamide, that's going to cause you to have and then your platinum base is going to be neurotoxin. Now age and cancer. So cyclophosphamide, that's going to that's pulmonary fibrosis is going to be what? Hemorrhagic cystitis, right? Hemorrhagic cystitis. So remember, your abdominal adenocarcinoma, that's going to go to the liver, and your cyclophosphamide is going to cause you to have hemorrhagic cystitis. Now, as you get older, you have increased risk of both lung cancer and also breast cancers. Thyroid cancer can be at any age as well, and maybe your primary bone tumors are only going to be seen in children. Good. Cancers are good. Now, alternative care, you can do BRCA1 and 2 testing, right? Now, with this is going to be spot breast cancer and ovary cancer a little quicker. Good. And you can do testing that way. Now, hyponatremia. So when we say someone has hyponatremia, what we say there, they have low sodium, right? And low sodium means that you're hypotonic. So how do you treat someone who's hypotonic? You're going to have to give them, you can do two things. You can either put, you prevent it by just putting saline in their IV fluids, right? Don't give them the D5W. Then you're going to treat them with hypertonic saline. I think either 3% in 300 or 5% in 100 or something like that, right? That's how you're going to treat it. Now, when you be hypotonic, what basically happens is that you have too much antidiuretic hormone. Antidiuretic hormone, what's going to do is it's going to increase water reabsorption. You have too much free water in your body and excrete the sodium. This can happen in two ways. If you have your syndrome, if you have too much antidiuretic hormone, which happens in syndrome of inappropriate antidiuretic hormone, or following post-op, because when you have trauma and increased ADH, or if you have, what else are you going to have free? Or if you lose a large amount of isotonic volume that's not replaced, and that you're forced to retain your water, and hence if it's not replaced, you're going to have hypotonicity. Good. Rapidly, if it occurs, you're going to have central nervous system coma. Then if it occurs slowly, what happens here, like in your syndrome of inappropriate antidiuretic hormone, you're not going to have central nervous system because your brain adapts. Good. And the other one, okay, rapidly developing hyponatremia, in which you have too much, like you said. So when you have post-op increase in antidiuretic hormone, this is going to cause water intoxication because there's too much antidiuretic hormone there. You can possibly die. So you can have a coma, convolutions. You can have a death as well, right? And and here you need to use hypertonic saline. Good. Now slowly developing hyponatremia, like in such as your inappropriate antidiuretic hormone. Here, all you can do is you should do water therapies. It's going to be water restrictions. Now, in the event where you have isotonic saline loss that's not replaced, or isotonic fluid that's not replaced, and you develop hypotonicity. Here, if your pH is neutral or acidic, you're going to give someone your ringer lactate. But if they're going to be alcoholic, you're going to give them the other one, lactate, I believe. No, normal saline. Normal saline, got it. Good. Oh yeah, too much. I'm going to do that again. Good. Now, carcinoid syndrome. This is going to be seen someone who has small bowel carcinoid syndrome that metastasized to the liver. Now, signs of this are going to be flushing in the face. You're going to have watery diarrhea. You're You're also going to have like right heart valvular problems like elevated jugular vein distension, and you're going to have, we said wheezing, I guess, right? Then sign, okay, good. Now, 24-hour urinary 5-hydroxynolic acid is going to actually confirm that diagnosis. It's going to be small bowel metastasis to the liver. Good. So many little details. Is that true? Good. Now, classic picture of acute appendicitis. So your appendix, right? So your appendix, what are you going to have over here? I think the thing with appendicitis is that it's going to be lower left quadrant pain and tenderness, right? Then you're also going to have, what else? You have certain signs over here. I know you're going to have fever, leukocytosis, I believe. And you're going to have, let's see. So you have anorexia. So you have anorexia followed by vague periumbilical pain. That several hours later becomes sharp, severe pain localized to the right upper quadrant. You have rebound tenderness, tenderness and guarding around the right upper quadrant, and right below the umbilicus, right? And remember rebound tenderness, right? Tenderness and guarding, which that's actually true. If you have the Rothstein sign, appendicitis, right? Rothstein sign. And you have modest fever, leukocytosis 10 to 15,000 range, and the neutrophilia, okay, which should follow. Good. So, signs of appendicitis is that you're going to have vague periumbilical pain, and several hours later, with anorexia and vague periumbilical pain, several hours later, what's going to happen is that it can become sharp, severe, constant pain localized in the right upper quadrant, right? And when you palpate the right upper quadrant, right lower quadrant, right? And when you palpate the left lower quadrant, you're going to have pain in the right lower quadrant. That's how it is, right? And you're going to have tenderness and rebounding are going to be on the right and below the umbilicus, right? Right and below the umbilicus, nowhere else. And you're going to have moderate fever and leukocytosis in that 10 to 15,000 range with moderate neutrophilia as well. And good. Emergency appendectomy should be done. Then other presentations that could be is that it's going to be so you're going to diagnose it with the CT of the right lower quadrant, as well as fucking up big time. That's what happens when you skip a day of review and you also you don't know anything. That's why it's important to always review shit. Now, acute ascending cholangitis. So like we said over here, what happens here is the cystic duct that the gallstone gets displaced and into the common bile duct over here, and you're going to have a partial obstruction of the common bile duct and ascending infection leading to like hallucinations of like central nervous system signs, right? And then signs you're going to see over here for acute ascending cholangitis is that you're going to see someone it's going to be a very old person, a very sick person as well. They're going to have a fever of 104 to 105 degrees, and they're going to have fever, chills, and also they're going to have high white blood cell count indicated with sepsis. Are you kidding me? There's ads in this too. Honestly, like everyone wants to make money now. There's ads in the study with me thing. Jeez. Okay. So then on top of that, you're going to have a very, very high level of you're going to have hyperbilirubinemia and a very, very high level of that other thing called alkaline phosphatase. Got it? Now the treatment for these ones for acute ascending cholangitis. What's going to happen there is that you need you need IV fluids, IV antibiotics as well as IV antibiotics, right? As well as immediate decompensation in the common bile duct. You can do that via endoscopic retrograde cholangiopancreatogram. If you cannot do it, you can also do transhepatic cholangiogram as well. No, percutaneous transhepatic cholangiogram and surgery as well. And then followed by cholecystectomy, removal of the gallbladder. Now, obstructive jaundice, when does it occur? Is that when you have it can occur in the absence of acute ascending cholangitis, when you have a complete obstruction in the common bile duct. Then presentation, again, you are going to have, we already know this, but you're going to have complete obstruction, which is even the hyperbilirubinemia, moderate amount of AST, ALT, and high amount of alkaline phosphatase. We know exactly how that's going to work. Good. Is that right? Good. Okay. Now, intraoperative tension pneumothorax. Who does it develop in? So it develops for someone who has seriously traumatized lungs, who has like trauma to the chest or something over here, and you have punctures from like broken ribs, and you're going to be exposed to positive airway pressure. Now the signs over here is that you're going to be very, really difficult to ventilate because you have shortness of breath and all that, and you're going to have a decreasing blood pressure and increasing central venous pressure. Now treatment for these ones is that what you need to do here is if your abdomen is open, you can immediately take compensation via the diaphragm. But if it's closed, what you're going to do is enter the chest tube high, so in the upper lobes and anterior, and then connect it to an underwater seal, and that's how you're going to pressure. Good. Now, acute abdominal pain caused by perforation. Now, perforation usually it's going to be by peptic ulcer perforation here, and treatment for these is that you're going to do nothing per oral, IV fluids, and nasogastric tubing as well. And what happens here is that it's going to be, I believe this is going to be constant pain. That's going to be severe pain as well. And constant pain, that's going to be severe pain as well. And signs over here, you're going to have rebound tenderness, guarding, fever, and leukocytosis. And tests you're going to see here is that you're usually going to have air under the free diaphragm, which is going to be confirmed with an upright x-ray. Good. Not true. Sudden onset of constant generalized pain and very severe. Now, patient's actually going to be reluctant. Patient's going to be reluctant to move and be very protective of the abdomen. Very old. Good. If present. Good. Emergency surgery is needed. I fucked up. So acute pancreatitis. So you're going to expect acute pancreatitis in an alcoholic who develops upper acute abdomen, and the pain is going to be you're going to have a rapid on. You're going to have a pain is going to be constant, very severe epigastric pain. It's going to radiate to the back, and you're going to have nausea, vomiting, and retching, and also you're going to have a rapid onset of inflammatory signs as well, inflammatory processes as well. Especially pancreatitis, no systemic signs, no fever, no leukocytosis. And how to diagnose here is that you're going to do, you're going to look at your serum amylase, serum lipase levels, right? And if you look at your serum levels, you can do between 12 and 40 hours. Urinary, you can look at between days 3 and day 6. Treatment for this one is going to be nothing per oral, IV fluids, and nasogastric suction. Good. And then remember, CT, you do CT, these are not unclear. Good. Okay. Now, anal fissure. Now, fissure. Fissure is going to be usually in young women, right? And the pain is going to be very, very intense and severe pain when they go to sit, and also when they have bowel movements, right? And the bowel movements are going to be covered in blood. And what happens is it's going to be so painful that they're not going to want to go to the bathroom, so they're going to develop constipation, and it's going to be so painful that you cannot do the physical exam on them. They're reluctant. So what you do, you put them under anesthesia when they go to do the physical exam. And fissures, the way they're going to work is that fissure, right? It's good. Good. Then you have the fifth one. And then causes of a fissure is just going to be a very, very, very tight sphincter. So first off, you can do is you can do stool softeners, right? What else can you do? You can also use topical analgesics. You can use injections of Botox. You can do forceful dilation, or you can do your lateral internal sphinctectomy, right? Lateral internal incision sphinctectomy. Good. Now understand that if you use your twice or 3 times per day calcium channel blocker, which is going to be nifedipine, you're 80% of the time it's going to be resolved. You don't need surgery. Versus the 50% of the time when you do Botox injection. That's what we're trying to do. No, diltiazem. Topical. Remember, you have your topical nitroglycerin, right? Topical nitroglycerin, lateral internal sphinctectomy, right? Nifedipine, no, diazepam, right? So we have your topical nitroglycerin, and then we have your calcium channel blocker, which is going to be your diltiazem. Good, don't forget that. Diltiazem for 6 weeks, 3 times a day, 6 weeks. Diltiazem. Come on, man. Okay. Now types of anal fistulas, right? Remember, you always have your low output, high GI fistulas, which low output is going to be your draining about 200 to 300 milliliters per day. It's going to be located in either the duodenum, the jejunum, or the stomach. Then you're going to have the high output, which is going to be several liters per day, and the same thing, high GI. Good. Okay. Now, gastric adenocarcinoma. Now, when you have a gastric adenocarcinoma versus gastric lymphoma, just know that you can have like a low-grade gastric lymphoma, also known as myotoma, that you have some sort of transformation occurring, but this transformation can be reversed if you eradicate the H. pylori, right? Now, you diagnose, gastric adenocarcinoma, it's usually going to be in elderly patients, and the signs here is that you're going to have someone who is going to have early satiety, right? So you're gonna have weight loss, anorexia, and early satiety. They're not gonna eat that much. And then how to diagnose this? I think you're gonna do here is that you diagnose it via biopsy and colonoscopy, and surgery. Surgery is going to be the best treatment, which is, I forget what it is. And then when you gastric lymphoma, again, elderly patients, and again, you're going to have weight loss, anorexia, and also early safety as well. But how to diagnose here is going to be, again, colonoscopy plus biopsy, but here you're going to have chemotherapy and radiation is going to be it. And then that's going to be, let me see if I got that right. So, the gastric pain. So, occasional hemotesis. So here you're going to have occasional hemotesis. So occasionally you're going to be throwing up blood, hemotesis, good. And then endoscopy plus biopsy are going to be diagnostic, and then CT helps. CT helps assess the operability, right? So so you're going to do endoscopy and biopsy to be diagnostic. CT is going to help assess the operability. And then gastric adenocarcinoma, again, okay, good. Now, the treatment based on chemotherapy, radiation, surgery is done. So again, so chemotherapy, radiation is going to be the treatment. You're going to do endoscopy plus biopsy to be diagnostic. But when you have a gastric lymphoma, you might need to do surgery only if that after the chemotherapy radiation, your fear of the whatever the lymphoma is going to kind of melt down, perforate to make some sort of perforation in the stomach. That's when you need surgery. Good. Okay. Now, magnetic resonance cholangiopancreatogram, right? This is going to be for imaging, right? It's going to be it's going to be more diagnostic, right? And this is going to be something that's going to be done within within 10 minutes, non-invasive, no injections, nothing like that. Or you might have to hold your breath for a couple minutes, or for like 10 seconds, and then you're done. Now, it's going to be very, very simple, non-invasive, and you get beautiful images of the pancreatic duct and also the common bile ducts. Now, if you want just to be diagnostic, if you're looking for just images, magnetic resonance cholangiopancreatogram, right? If you need to do a little more, then you can do the all-day event, which is endoscopic pancreatogram, which can do a lot of things. Okay, now traumatic rupture of the diaphragm, again, signs is going to be where you're going to have bowel on the left side of the chest. By physical exam or x-ray, you're going to see that, and then diagnosed by laparotomy, and then you're going to do you're going to also do abdominal surgery to fix it. Then when you have traumatic rupture or transection of the aorta, the ultimate hidden injury, where does it occur? It's going to occur at the branch, at the aorta arch and descending aorta bifurcation. And how does it occur? Deceleration injuries, where you come to a sudden stop like a car crash, and you're going to have a rupture. It's usually asymptomatic, but only symptomatic when you have a rupture of the hematoma, and eventually which patient suddenly dies. How to diagnose here in a traumatic setting? You're going to do your spiral CT or CT angiograph. Non-traumatic, again, you're going to do transesophageal echocardiogram, MRI, or CT spiral. Good. Now, hyponatremia is that, remember, you're going to have too much loss hyponatremia here is where you're going to have you have too much water intake, right? And because of that, you're going to be hypotonic. And again, rapidly can be caused by what? It can be caused rapidly by, I know it can be caused slowly by syndrome of inappropriate antidiuretic ADH, and then it can be caused rapidly by water intoxication, which is post-op, right? And again, so rapid treatment for this one is that you're going to do what? Hypertonic saline, 5% to 3%, and then slowly what you want to do is that you want to just put a restriction on how much food you're taking in. Good. And then if you're now, acute pancreatitis in the pancreas. Now, again, so we have amylase lipase levels as well. Now, when's it going to be seen? So we see acute pancreatitis when? You're going to see it as a complication of in alcoholics, or as a complication of gallstones, right? Good. And then types, you can have pancreatitis, you can have your edematous, you can have your hemorrhagic, or you can have your suppurative, or your pancreatic abscess, right? Late complications is going to be your pseudocyst, pancreatic pseudocyst, or your chronic pancreatitis. Good. Okay, now, traumatic. So what are the signs of internal bleeding or intra-abdominal bleeding? It's going to be signs of shock. So you're going to have a low urine output below 0.5 milliliters per day, or per hour, I guess, right? You're going to have a decreased blood pressure. You're going to have a high pulse. You might have a high pulse, right? You're going to be diaphoretic, sweaty, nervous, anxious, all that. But it's going to be, remember, you're going to have the blood pressure is going to be low, high pulse, and low urinary output. Now, explain it, because what happens here is that if you have intra-abdominal bleeding, you're going to have a lot of of blood loss within the cavity of the abdomen. And how to diagnose it is that you have to do an x-ray of where? The pelvic, the pelvis, to see the femur, or the chest to see if you have broken bones there, because those are the only places that can actually house that much blood. When you do these tests, once you're hemodynamically stable. Good. Now, good. Then, if you have no other doubt to believe why you have symptoms of shock, then you probably have intra-abdominal bleeding. Good. Now, so drop blood pressure, shivering, cold, pale, sweaty. Good. Good. And then fast pulse, and then 25% blood loss in 100 milliliters. Now, if you give the patient, if you stabilize the patient, you give them fluid, no surgery is needed when you're done. Okay. Now, carcinoid syndrome, like you saw over here, and then, so classical signs of acute appendicitis and appendix. So first off, you're going to start off with anorexia and very vague periumbilical pain that's going to develop into sharp, severe right lower quadrant pain. Remember the sign of appendicitis, the Rothstein sign? If you palpitate the left lower quadrant, you're going to pain in the right lower quadrant. Got it? Now, again, those are going to be the signs of it. And with pancreatitis, you're also going to, then how to diagnose this is you're going to do a CT, that's going to diagnose it. And treatment here is going to be emergency appendectomy. Labs you're going to see over here is going to be, you're going to have a fever, right? A moderate fever, leukocytosis, in the 10,000, 15,000 range with neutrophilia as well. Now, when you have doubt presentation of appendicitis, it's going to be, again, you're going to do CT scan. It's going to be all the sign types. You're going to have signs of appendicitis, but it's not going to be the classical picture. Okay, acute abdominal pain caused by obstruction. Now, when you have the acute abdominal pain caused by obstruction, this is the one that's going to be colicky, right? Meaning it's going to come and go again, and you're going to have acute come and go pain. And patient is going to be, when you call by obstruction, patient is going to be constantly be moving to get positional relief. Location is going to be colicky pain anywhere where the obstruction has occurred, and pain is going to be colicky and yeah, it's going to radiate to wherever the associated organ is. Now the obstruction is going to cause the narrow ducts like the cystic duct, the ureter, or the common bile duct. Good. Now when you have acute abdominal pain caused by inflammatory process, this is where it's going to happen, where it's going to start off as very ill-defined, constant generalized pain. Then it's going to, several hours later, 6 to 12 hours later, it's going to really localize to a single spot. It's going to radiate, right? See that? Fine. And then the physical signs, you're going to have rebound tenderness and guarding, and also fever and leukocytosis, except for pancreatitis. Good. Slip capital femoral epiphysis. This is going to be a surgical emergency for children. It's usually going to be seen in where? I think it's going to be seen in like 13-year-olds who are a little bit obese. And here you're going to have autologous gait again, and also you're going to have limping is going to be occurring. You're going to have hip pain and knee pain, right? And the only thing to do here is you're going to have fixation of the femoral head into the acetabulum, right? You either by putting in a cast or crutches. That's how you're going to treat it. Now you're going to do anterior, posterior, lateral view. X-ray is going to be diagnostic. And then physical exam, again, is going to show pain and all that. Signs of a typical patient, and good. Nope, I got it wrong. So it's an orthopedic emergency, right? Right, and then what happens here is that you're going to have typical patient is going to be like a chubby, obese, like a chubby 13-year-old, right? Complains of groin pain or knee pain and limping, and then when the leg is dangling off the side of the table, the affected foot, side of the foot is going to be angled towards the unaffected foot. The unaffected foot. On physical exam, there's going to be limited hip motion, and when the hip is when the hip is then as the hip is flexed, so the hip flexion. The thigh goes external, undergoes external rotation, cannot be rotated internally, externally rotate, an X-ray is going to be diagnostic. In surgery, is put surgical pins into the femoral back in place. Good. Redo that too. Now, acute abdomen caused by perforation. describe the pain. Now this is going to be the one you have a sudden onset of severe pain. Severe pain, and patient is going to be reluctant to be moved because of the pain, and it's going to be you're going to be guarding the abdomen, so you're going to have rebound tenderness and guarding fever and leukocytosis. Now, test for these is going to be you're going to have a free area on the diaphragm, which is going to show on your upright X-ray. Pelvic ulcer can perforate, and treatment here is that is surgery. Good. Okay. Now, when to conduct early excision of a burn and skin grafting. So it's done to reduce the suffering of the patient, also for cost effectively, right? And you start day one with a third degree burn, right? And when it's going to be done, it's going to be done on third-degree burns in adults with less than 20% covering less than 20% of the body. Good. Third-degree burns covering under 20% of the body. Removal of skin of burn area followed by immediate skin grafting, right? So what occurs? So you have removal of skin on or skin in, or removal of skin like the burn areas and the immediate skin grafting, right? Good. Now treatment for when you have a small bowel, okay. So mechanical obstruction, or like, okay. So when you have an obstruction of the small bowel, we're hoping for a spontaneous resolution. So in order to maintain spontaneous resolution, that's where you do nothing but oral IV fluids as well as nasogastric suction. Good. I think that's what we hope for. Good. So good, IV fluids. Now, if it's going to be a complete obstruction and does not heal within 24 hours, surgical emergency. But if it's going to be like a partial obstruction, you can wait a couple days. Okay. Now, acute edematous pancreatitis. Now, this one's going to be the low hematocrit. Oh no, it's going to have high hematocrit. That's the key find. High hematocrit in this one. And when does it occur? So this occurs when you're going to have what? Labs, you're going to have elevated serum amylase or lipase. Elevated amylase and lipase, and you're going to have high hematocrit. Good. Now this occurs following what? This occurs as a complication in alcoholics or a complication of gallstones. Now symptoms you're going to have is what? Alcoholic or with gallstones, right? You're going to have epigastric or mid-abdominal pain that starts after. So you have epigastric or mid-abdominal pain that's going to start after a heavy meal or bouts of alcohol intake, right? It's going to be constant. It's going to radiate straight to the back, accompanied by nausea, vomiting, and after if you have the stomach, you're going to have retching. There's tenderness and rebound tenderness in the upper abdomen. Amylase and lipase are going to early on. Okay, good. And then key findings. Elevated hematocrit. Resolution following 3 days of pancreatic rest. Good. Fuck the whole thing up. So when does it occur? In someone who has gallstones or an alcoholic, his symptoms is that you're going to have severe upper abdominal pain or epigastric or mid-abdominal pain after you eat a heavy meal or after drinking alcohol, and the pain is going to be constant. It's going to radiate to the back, and you're going to be raised to the back, accompanied with nausea, vomiting, and if you want to you're going to have retching as well. Now labs are going to have high amylase and lipase. It's going to be high early on in the serum. Third to 6 days, going to be high in the urine. You're also going to have high elevated hematocrit. Treatment here is going to be pancreatic rest, nothing for IV fluids, and nasogastric. Okay, gastric adenocarcinoma, again, it's going to be seen in the elderly who have signs of what? They're going to have anorexia, weight loss, and like mild distended abdomen as well, and also they're going to have signs of hematesis. How to diagnose here is that you have to do endoscopy plus a biopsy, and then you're also going to do a CT scan to assess the operability. Treatment surgery is always the best option. Now, in terms of gastric lymphoma, again, it's going to be in elderly patients as well who have anorexia, weight loss, and also like abdominal tenderness. Maybe have hematesis, and then here you're going to do endoscopy, plus you're going to do a biopsy to diagnose it. But to treat it, you're going to do chemotherapy or radiation. But the only time you do surgery for this is if that you do so much radiation or chemotherapy that that tumor melts off and you're scared of perforations. Now, but understand here that if you're going to have like a low-grade lymphoma, called meltoma, you can reverse it by eradicating the H. pylori. Now, gallbladder terms, cholecystitis is going to be gallbladder inflammation. Cholangitis is going to be biliary duct, and then cholecystectomy is going to remove all the gallbladder. Good. Okay. Now, bacteremia. Bacteremia, this is going to be developed intraoperatively in patients who are getting like an operation that requires instrumentation, like instrumentation of the urinary tract. And here you're going to develop a very, very high fever, as well as what? High fever, and you're going to treat it with you do a blood culture, and then you treat it with the appropriate antibiotics. Now you're gonna have a high fever and chills, right? But if you have like a wound and you're gonna have heat within an hour, like hours in the surgery, you're gonna have severe pain and fever. You have to look out for gas crepitus. Good. Come on. Do a blood culture 3 times. Bacteremia, do a blood culture 3 times. Don't forget that. 3-time blood culture. Okay, now gallstones. Gallstones, right, they're going to be stones, okay? The importance is that gallstones is, a textbook victim is going to be like a 40-year-old obese woman with many kids and high alkaline phosphatase. That's going to be okay. And then the importance is that they can cause many biliary tract, like biliary tract infections and diseases. Asymptomatic gallstones, we just let them be. We don't do anything. We just observe them. Good. It'll also be Mexican Native Americans as well. They'll be Mexican Native Americans as well. Okay. Now pancreatic abscess. Now this is supported pancreatitis. Now this is going to be when you have a pancreatic abscess. What happens over here? So how are they going to be found? They're going to be found via like a CT or something like that. And treatment is that you need to have surgical excision to drain these. Surgical excision can be dependent in a couple of ways. And necrosectomy is going to be removal of dead tissue from the body, usually your pancreas, and it's the only way to deal with a necrotic pancreas. And you might have to do it. You're going to scoot the pancreas out, and you're going to have to do it a couple times. Good. And then pancreatic abscess. How's it going to be treated? I know you're going to use antibiotics, IV fluids, nothing for oral, and also just forgetting all this. Now, so pancreatic abscess comes to surgical attention via imaging studies, or when fever and leukocytosis develop 10 days after the onset of pancreatitis. Ideally, you want to use percutaneous radiological drainage. Should be performed best open drainage products, right? So how pancreatic abscess can be found? Usually it's going to be found via like a CT scan, surgical via imaging like a CT. But it comes to surgical attention if you have fever and leukocytosis developing 10 days after the onset of pancreatitis. Treatment is percutaneous radiological drainage, but if you cannot do that, open drainage is fine. Okay, now pelvic fractures. Now, when you have your pelvic hematomas, a bruise that's asymptomatic, observational therapy is good, like expected management is good. But when you have a pelvic fracture, you got to look out for what? In men, you have to look out for urethral damage, urethral injuries. Females, vaginal injuries as well. Which you're gonna do I think you're gonna do like a prostate. How do you do? Prostate exam or something like that. Retrograde cystogram over here. And then in any case, you look out for bladder injuries for both male and female. Bladder injuries, and also you're gonna look out for bladder injuries and rectal injuries, which is process. Good. Now, a specific significance of pelvic fractures is they can lead to hypovolemic shock because you're going to pool blood in there because you have a lot of blood loss. The treatment over here is that surgical expiration always. Good. Big hematoma. If they're not expanding out alone. Good. So typically that's not expanding. So pelvic fractures, associated injury had to be ruled out. So we have rectum, so do a rectal exam, proctoscopy as well, and bladder. So okay, both sexes, right, and do a pelvic exam, and then in urethra, which we use. Oh, I don't know why I mixed up pelvic with prostate. Good, and then good. Now pelvic exams can be hypovolemic shock because in pelvic, so they can pull blood. The treatment over here is going to be always the first thing you want to do is first. So you want to immobilize the pelvis the best we can, and we do the first binding or external fixation, the second immobilization. So we want immobilization of the pelvis, right? So you want to immobilize the pelvis, so put it in the cast, and then we do the first with binding or external fixation, second with immobilization of specific bleeding arteries like the internal iliacs or the venous, right? Yeah, this in there. So fixation. Immobilize the pelvis with what? Fixation. And then embolize iliac, internal iliacs, bleeding arteries. Now, types of jaundice, right? You have hemolytic jaundice, we have obstructive jaundice, and hemorrhagic jaundice, right? Now, when you have hemolytic jaundice, what do we have here? So you're going to have increase in your bilirubin, hyperbilirubinemia, only unconjugated, got it? And when you have that's your hemorrhagic, and no hemolytic, right? And your hemorrhagic, you're going to have elevated indirect and indirect bilirubin, so hyperbilirubinemia. You're going to have high levels of AST, ALT, so transaminases, and moderate elevation of alkaline phosphatase. In your that's no hepatocellular, that's hepatocellular, right? And the most common hepatocellular is going to be you're going to have your hepatitis. Good. And then obstructive jaundice, you're going to have elevated, unconjugated, conjugated, right? Your modest elevation of AST, ALT, but a really high level of alkaline phosphatase. Good. Now, unconjugated, there's going to be a low rise, no bile in urine, right? So we're going to see over here. So it's going to be a low rise of unconjugated bilirubin, right? So it's going to be like not really that high. So like 6 to 8, not 30 to 45 rise, right? And there's no bile in urine, and it's going to be an elevation of direct, a low rise in elevation of what? No rise. With no elevation of okay, good. Okay, now slip capital for morphitis. This is going to be an orthopedic emergency, right? And what happens here is you're going to be a 13-year-old who's a little bit chubby, and you're going to have hip pain, usually knee pain, right? And you're going to walk with a limp, and a limp as well. And when the kid's sitting in the affected foot is going to be inverted towards the unaffected foot, and when you have flexion at the hip, it's going to cause external rotation of the thigh, and which cannot be internally rotated. Again, with these stupid ass heads. Good. And then you need a placing surgical pins to lock in the X-rays immediate anterior posterior lateral X-rays immediate diagnostic, and then pin placement, surgical pin placement of the femoral head into the sternum. Okay, now primary hepatotoma or your hepatocellular carcinoma, it's going to be seen in who? It's going to be seen in patients with hepatitis B or C, or patients with cirrhosis, adults as well. The signs over here is that they're good. And then diagnostic markers is going to be your alpha-fetoprotein, and it's diagnosed. You can see it via CT scan, and the diagnosis that you see how to use it. Hepatoma, right? So cirrhosis knows with hepatitis B or C, you're going to have vague right upper quadrant pain, discomfort, and weight loss. Right upper quadrant pain, vague right upper quadrant pain, and weight loss. And then alpha-fetoprotein CT scan and show location, extent, resection is done if technically possible. Metastatic cancer of the liver. But just so you know that metastasis of the liver cancer is a lot more common, 20 to 1 common than primary cancer of the liver. Now, how to diagnose here? Again, I think you need to do CT scan. So the way you diagnose metastasis of cancer is that it's going to be following a CT scan for a follow-up, and a primary cancer has already been treated. Or if you have colon cancer and you have normally elevated carcinoma embryonic antigen, good. Now that's how you diagnose it. And treatment usually is going to be so if the primary tumor you have is slow growing, and thus the metastasis is confined to like one lobe of the liver, you can have resection. Resection can be done. Other means controls chemotherapy is radioablation. Good. Endoscopic retrograde cholangiopancreatograph, right? And what's it used for? It's going to be used for both instrumentation and visualization and imaging of the pancreatic duct and the biliary duct as well. the biliary, the common bile duct, right, and the pancreatic duct as well. Now, how does it work? Is that this is going to be an all-day event where you insert an endoscope and through the endoscope, right, through the duodenum, and you have your ampullary canalization. And this whole thing's going to take about 1 hour to do the endoscopy, but it's going to be an all-day event because it involves anesthesia, right? And this requires, you might have some sort of like gagging if you're not getting anesthesia. You're going to need a ride home following, right? And what happens here is that in addition to the imaging of the pancreatic duct and biliary duct, right, you're also going to be able to do sphincterectomies in this way. You're going to be able to do removal of gallstones, right? You're going to be able to do biopsies. You're going to be able to do abscess training. What else are you going to do? Hysterectomies, training. Right, and then remember, your X-ray dye is going to be injected. All day affair, and then perhaps gagging, and then endoscopic, and then what else can you do? Now, according to remember, you're also going to do stent placement as well. So it's diagnostic and therapeutic, right? Stent placement as well. Good. Now, acute edematous pancreatitis. This can be seen in alcoholics or patients who have gallstones. Got it. And symptoms you're going to have is you're going to have severe onset of epigastric pain, or like upper mid-abdominal pain following ingestion of heavy meals or bouts of alcohol, accompanied with this epigastric pain is going to radiate straight to the back. You're going to have nausea, vomiting, and retching if it's on an empty stomach. Labs is that you're going to have elevated amylase and lipase, and the serum is going to be within the first really early on. Urinary is going to be later on. Then you're also going to have very high hematocrit. Now, treatment is going to be pancreatic rest, IV fluids, nothing oral, and nasogastric suction. Good, resolution after heat is good. Now, cause of vasomotor shock. Okay, so remember the cause of vasomotor shock is that remember you're going to have hives, right? And when you have hives, you're going to have a low central venous pressure, so you're going to have vasopressors to be treating this, right? Which you're going to use epinephrine. And epinephrine, you're either going to use 0.3 to 0.5 milliliters in a 1 to 1,000 solution for this one, right? And when you have vasomotor shock, it's going to be due to like an anaphylactic reaction, such as like getting like a bee sting. And you're going to have wheezing, right? A pink, worn face as well. And the signs is, and that's the treatment, right? Epinephrine, and then how the vasopressors. Then shock, and then good. Signs going to be like anaphylactic reaction, like a bee sting. Also, it can be due to anaphylactic reaction. It can be the high spinal anesthesia, or high spinal injury. High spinal cord transection or high spinal anesthesia. Restore peripheral resistance, right? Vasopressors. Yeah. Good. Okay. Now, human bites, they're the most bacteria-filled bites, right? Now, treatment for these ones is you always want to give a tetanus shot. You always want to ensure to go to the brine and clean the wound. You're going to be someone who has like a edematous, tender knuckles, whatever, and they're going to have a fake story how to hide it. Now, again, always tetanus and always tetanus shot, always debridement. Now, treatment for these ones, what else are you going to do? I think you're going to put them on IV antibiotics as well. You need antibiotics for these. Tender, swollen, erythematous. The axillary irrigation. Good. Okay, now pancreatic abscess. Now, pancreatic abscess, supportive pancreatitis, how are they going to be found? This is going to be found usually in someone who has it's usually found by imaging like a CT, or someone develops fever or leukocytosis, it becomes surgical attention, we get fever, leukocytosis 10 days after being diagnosed with pancreatitis. Treatment for this one is that you need to have drainage of this pancreatic abscess, either radiological, percutaneous radiologically, but if not, you can do open drainage, it's fine. Good. Okay, now combination. Okay, now penetrating injuries for extremities, right? So other extremities. Now, when you look for penetrating injuries, what we're really looking for here is you're looking for any sort of vascular or neurological compromise. That's what we're looking for, right? So if you have a penetrating injury and there's no vascular compromise, you can do like, and there's no major vessel or involved in the vicinity here, that you can just expect management, just observe it or wrap it up, and that's good. Debridement, that's good. And if you have if there's vasculature around the area here, which one do we here? The penetration is near major vessels and patient asymptomatic. I forgot that. So okay, let me go to the next question. A combo of damage to the arteries, nerves, and bone. First thing you want to do, you want to assess the bone, right? You want to put the bone in the cast and realign the bone. And then you want to fix the arteries, and then worry about the nerves. Good. What else to add? You also want to do prophylactic fasciectomy just because if you have compartment syndrome. Good. Now, Doppler studies and angiograms are done. Good. The main issue, vascular, whether it's vascular injury has occurred anytime over any one case. Preparation, penetrating there is obvious vascular injury like absent pulse or hematoma, then surgical pushing repair required. Now here, obviously, the first thing to do is stabilize the bone, then do a delicate vascular repair, shut down otherwise good, and then leave early nerve flash. Salad, some birthday. See. All right. Ulcers from arterial toxicity. When you have ulcers from arterial toxicity, they're going to be as far away from the heart as possible. Usually, they're going to be in like the toes, right? Now, these ulcers, when you look at the description, I think they're going to be pale, dirty looking, pale with granulation tissue at the bottom, right? And the complications, usually going to have some sort of other like arterial occlusive disorder as well, such as like absent pulse, resting pain, and claudications. And how to diagnose here is that you're going to do a Doppler exam first, or duplex, I believe, which is imaging plus Doppler, for like a pressure gradient to be established. If none of that means no sort of surgery can help us with any microvascular complications. How to diagnose, in addition to that, and then following that, you're going to do an MRI or CT angiograph, followed by either stent placement or surgical revascularization. From arterial, good. Dirty. Remember, they're going to be bases. They're going to be devoid of it. So they're going to be dirty looking, but they're going to be devoid of radiation tissue. Doppler, yeah. Okay. Pelvic fractures, treatment or pelvic. So remember, if they're not expanding, you don't treat them at all, right? Okay. So that means the pelvic. Now, when you have a pelvic fracture, what you want to do here is you want to test them both male and female. Any sort of rectal or disorders, you have to rectum, either doing a proctosigmoscopy or rectal exam. Also, you want to check the bladder as well. Then also you want to check for women. You want to check the vagina via a pelvic exam, and then males you want to check the urethra via the retrograde cystogram. What happens here is that when you have a pelvic fracture, you can have a massive hematoma, right, and intraoperative bleeding, right? So because you can have all that blood, so you can be hypovolemic shock. And how to treat this? If you do have signs of hypovolemic shock, you need to have surgical expiration and repair. Yeah. So what you want to do here is that you want to immobilize the pelvis and include the bleeding arteries, whether maternal larynx or any sort of bleeding arteries. Good. Now, types of jaundice we have for hemolytic jaundice. We have your hemolytic, we have your obstructive jaundice again, and then we have your hemolytic, and then we have your hepatocellular, right? Now, hemolytic jaundice, we said we're going to have a moderate increase in unconjugated bilirubin, very low, 6 to 9 increase, but no bile in the urine, right? And good. And then how to diagnose here, and then we're going to do look in the blood, so I'll be testing, and then hepatocellular here, we said all that, and then drop. Okay. Now, primary hepatotoma or primary hepatocellular carcinoma, or you have hepatocellular carcinoma with the seen adults with cirrhosis, hepatitis B, hepatitis C. You're going to have vague right upper quadrant pain. There's also a lot of weight loss as well. You're going to alpha beta protein as the marker and do a CT scan to be diagnosis and resection if needed. Resection if you could. Good. Now, metastatic is going to be more common than primary liver cancer, 21 odds, right? And how do you diagnose it? Usually it's going to be like a CT scan of already treated primary cancer, or you can have a normally elevated carcinoma embryonic antigen in someone with colon cancer. Now, we said to treat this, right, if you have a very slow growing primary cancer, you can do just a lobectomy, like a removal of one lobe, or you can do radioablation. Okay. Now, penetrating injuries of the extremities. We're looking for any sort of vascular injury. So if you have like an injury to an extremity and there's no indication of no major vessel involved, what you can do here is just like tetanus shot and clean up the wound. That's all it is. That's all. Tetanus and clean up the wound. Good. But if if it's in an area where there's vasculature, you want to do a Doppler to assess the vascular integrity. If there's clear indication of vascular injury, such as hematoma or absent pulse, then you want to do surgical expiration, surgical repair. Now, combination of so first off, you want to fixate the bone, make sure it's stabilized, and do careful arterial repair of the vasculature, and then nerve after that. And you have to do prophylactic fasciectomy for compartment syndrome. Mechanical bowel obstruction. Now, the column is usually paralytic ileus. Paralytic ileus is usually going to be post-op day 1 following a abdominal surgery due to adhesions. And when you have these adhesions, you're going to have no passage of gas or feces, right? No absent bowel sounds, and moderate abdominal distension, and it's going to resolve by itself usually. So paralytic ileus is right, but there's no pain. Then paralytic ileus is actually going to be expanded or prolonged by hypokalemia. Potassium. Good. And then when you have your mechanical bowel obstruction, what you thought it's going to be due to adhesions, which you thought was a fairly ileus after 5, 6, 7 days does not heal, then that means you probably have a small bowel obstruction. And our test and all this is that when you do the CT is going to be diagnosis, which is going to show like the proximal segment is going to be very dilated segment of the small bowel, but the distal segment is going to be your obstruction is going to be collapsed, and you're going to have air fluid levels to be seen in upright positioning when you do on a chest X-ray as well. And then in order to treat this is going to be we said IV fluids, nothing per oral, and nasogastric suction. But you use surgery. You're going to do surgery if it's not here within 24 hours. Oh, good. Dilated loops and small bowel. Good. Good. Always. Dilated loops and good. Now, when you have Crohn's disease, Crohn's disease, rectal disease, Crohn's disease can affect it's multiple places in GI, can affect the rectum, and just understand here is that when you have Crohn's disease, you never want to perform anal surgery, rectal surgery. Significance of this and progression and detection. So what happens here is that in Crohn's disease, what starts as like a small ulcer, a fistula, or like fissure that's not healing, and it's going to get worse following, or it's going to get worse following surgery, and that's how you know you have Crohn's disease. Because usually what happens is that the rectum should heal really quickly because it has a lot of air, or a lot of blood supply. That's how you know you have Crohn's disease. Now treatment over here is going to be IV fluids, antibiotics, and nothing for oral. And that's right. No surgery. No surgery. So affects the anal area. Let's start at the fissure, small fistula, diagnosis suspected. One fails to heal or it gets worse. Okay, after surgery, surgical intervention. And fistula. Now, the fistula is present. What you want to do here is you want to kind of like drain it with like setons or like cotton. You want to use cotton for that. Then I'm going to get there. Remicade can aid in healing. Now, ileorectal abscess, aka your perirectal abscess, good. Now, sign of this one is that lateral to the anus, you're gonna have this abscess, which is gonna be like red, tender, erythematous, all that stuff, all the signs. And treatment here is that you need to have drainage of this, surgical incision and drainage, good. And complications, so physical. And the patient is going to have fever, and you're gonna have exquisite perirectal pain. Do not let them sit down and have bowel movements. Good. And then it's going to be between the rectum and the issue of prostate. Surgery has to be done, and cancer should be ruled out by a proper exam during the procedure, which is going to be proctostigmoscopic exam. And then if the patient has severe diabetic or horrible necrotizing soft tissue infection, good. Okay. Now, a rule of thumb is that in any sort of anorectal disease, you always want to rule out cancer. No matter if it's a presentation, proctostigmoscopic exam and physical exam should be done. Now, hemorrhoids, right? You have internal and external hemorrhoids, right? So external hemorrhoids are going to be the painful hemorrhoids, right? Which are going to be painful. The internal hemorrhoids are going to be painless, they're going to breed bright red blood. And they become painful if they prolapse, and they're going to have a much pruritus as well. But then how you treat internal hemorrhoids can be rubber band ligation, while external hemorrhoids can be cured by conservative management surgery if done as you can. Good. Okay. Now, melena. Melena is why we're going to have dark terry stools, because you're going to have digestion of blood that's going to happen. So that's going to be an upper GI endoscopy diagnosis. And just like if you have a nasogastric tube suction, you pull out blood. Good. And then when you have bleeding, you have red blood in the rectum, which first you need to see is if it's actively bleeding. And this can be bleeding from anywhere, right? But it can be it can be bleeding from anywhere in the GI tract. It has a diagnosis. If you're an active bleeder, you want to do a nasogastric suction over here. And if you do pull out blood, that means you have an upper GI bleeding, so you're going to start with upper endoscopy. But if you do pull out like just white fluid, no bile, you can rule out from the ligament treads all the way to the pyloric sphincter. But if you pull out green bile, that means, or green to the bile, that you can rule out from the tip of the nose to the ligament treads, right? So the bottom can be ruled out. Right? Good. Now, so good. So yeah, good. Now, if you have bleeding for rectum and upper endoscopy has been ruled out, you're an active bleeder. First thing you want to do is calculate how much bleeding you're doing per hour, right? Or per minute. So you need to be between. But if it's going to be under 0.5 milliliters, what you want to do here is wait till bleeding stops and per minute, then do colonoscopy following. But if it's above 0.5, if it's above 2 milliliters per minute, right, 4 liters per hour, then what you want to do here is that you want to do angiographic diagnosis and embolization as well. It's going to be 0.5 to 2 liters where you want to do a tag red cell study, right? Which you're going to have pooling in terms of location, and from there. Remember the angiographic study can actually show you where it is. Okay. Now, so cancer of the right colon versus cancer of the left colon, right? So cancer of the right colon, usually it's going to be an elderly patient with no reason to have colon cancer, and this is going to show up as what? You're going to have anemia, which is going to be iron hyperchromic, so iron deficiency, anemia, so it's going to be deficiency in iron, it's going to be hyperchromic as well, anemia. Plus, you're going to have occult blood found in like trace amounts of feces, right? And you're going to do diagnosis is going to be by colonoscopy with biopsy, and this one's going to be where you're going to have surgeries in best, right hemicolectomies in best. Now, when you have left colon cancer, you're going to diagnose it by proctosigmoscopic exam plus flexible proctosigmoscope plus a biopsy, and then CT can assess the operability. Now, usually if you have a large rectal cancer, you're going to be pre-op chemotherapy and radiation for this one, right? And here it's going to be present with, you're going to have constipation, you're going to have blood, you're going to have bowel in the blood, and you're going to have blood covered, you're going to have stool covered in blood, as well as you're going to have narrow stool caliber to the constipation. Yeah. So proctosigmoscopic exam, full colonoscopy should be done. Remember, before surgery, full colonoscopy should be done to rule any sort of primary, secondary, or secondary tumors. Good. Secondary tumor. Right. Good. Now, bladder injuries. When do bladder injuries occur? Where you have like some sort of like blunt force trauma to the lower abdomen, right? You have bladder injury. And bladder injuries, how to diagnose here is that you're going to do a retrograde cystogram. You can either have, if you have retrograde cystogram, right? If you have external peritoneal leaks, polycatheter can solve that. Internal peritoneal leaks you can do here is that you can do suprapubic cystic, something like that. You can do associated with pelvic fractures, right? Retrograde cystogram, then X-ray. Then an X-ray, right? Retrograde cystogram, then X-ray, then surgical peripartum by suprapubic cystogram. Okay. Now, pulmonary risk for surgery, gravel risk. The most risk factor is going to be smoking. Then when to evaluate. If the patient has COPD or prior history of smoker, you always want to do airplay gases and you want to evaluate their forced expiratory volume. All right. So when you do smoke, it's going to cause reduction in your ventilation, right? Oxygenation. And you're going to have reduction. You're going to have an increase in your. I think you're going to have a decrease in your forced expiratory volume for 1 second, but an increase in your partial pressure of CO2, I believe, right? And workup for this one is that you're always going to start off with chest X-ray, airborne gases, and then actually before surgery, respiratory support, physical therapy, such as you want to stop smoking at least before surgery, and physical therapy such as respiratory support, respiratory therapy, and then you can do like humidified air, surfactant treatment, all that stuff. Good. Now, not my greatest performance, guys, but whatever. My own fault. So high PCO2, high population. Okay, you get a history. So start with you use forced expiratory volume, and then if abnormal, you follow with gases. Good. Now, Crohn's disease. Significance is that sometimes you can have the rectum could be affected by Crohn's disease. Progression starts as like a small ulcer, fistula that doesn't heal after surgery. It gets worse after surgery, which is kind of odd because that area has a lot of blood supply surgery. You could treat, but it doesn't have Crohn's disease. Good. And then treatment for this one is that what you want to do here, you never want to do surgery when you have Crohn's disease in the rectum. Instead, what you want to do here is that you want to treat it with a seton packing, drain with a seton or like a cotton, so you wait for medical therapy, primary not peeling. Now, ischiorectal abscess, which is between the rectum and the ischiotuberosity, lateral to the anus, is that you're going to have a patient who's in perirectal abscess, which is in severe perirectal distress. You can sit down and appreciate your pain with bowel movements as well. And it's going to be an abscess is going to be ruber, so red, tender, and warm. Then you need surgical incision and drainage of the best therapy. But complications, if you have a severe diabetic, you can have necrotic This is a rising of gross soft tissue. Who's on a rule out cancer as well? With proper exam, right? And right there, rule out cancer. That's the most exam. Good. Bladder leaks. When do they occur? When you have a pelvic fracture, and both males and females have a diagnosis here. There's a retrograde cystogram followed by an X-ray bladder. Then here you're going to have to do suprapubic. You can do a cystogram, surgical repair, then suprapubic cystogram. Cystostomy. Good. Stomy. Now, first off, you have to do a sports rewind. I don't know your glasses. Good. Okay, we finished the first review. Now I got to do another review of like shit I learned yesterday. It's gonna go worse than what. I'm surprised it's gonna go worse than what happened just now, but whatever. Oh my god! Don't tell me I have more review. I lied to you guys. I have more review. Whatever. I'm just a play date to you. Okay, septic hip. So septic hip is going to be usually toddlers who have a fever and refuse to move their hip. Now the child's going to be grabbing the affected limb, and it's going to be abducted, so towards the body, adducted towards the body, and flexed. It's going to be flexed, and you cannot refuse to move it. Now you're going to have high rhythm and ASR as well. Now the only way to diagnose septic hip is to do an aspiration of the hip. Aspiration, and like that way. So the orthopedic emergency. Slow tolerance, free run, freezing the hip. Then it'd be slightly abducting external rotation. So this flexed hip, slight abduction, so always external rotated. Good. Okay, dynamic aspiration under anesthesia. It's extremely needed. Good. Needed. Good. Now septic hip and slip capiform devices, and then abduction is going to be away from the body. Good. Okay. Now carpal tunnel syndrome. Now carpal tunnel is going to be seen like usually in females most of the time, right? But it's going to be females repetitive work with the wrist, like typing, and with stimulation in the radial 2/3, in the radial 2/3 digit in the median distribution team. Okay. And you reduce it by like tapping the carpal tunnel, the median nerve stimulation. Good. Then how to treat here is that you can use here is you're going to do the best thing is going to be like a splint and also anti-inflammatories and a splint, right? And then that fails, you can do surgery. Good. So then if that doesn't work here, you have to do a nerve conduction test to see if there's right. And then you can do you have to reduce the entrapment. Good. Now, when you have your trigger finger again, in females when they're sleeping, a slight acute flexion of the fingers. It's normally be undone, but can be done by snapping by forceful extension. And here, I think surgery is going to be the, surgery is going to be the best therapy, but you can use steroid injection as well. So steroid injection is the best therapy, but then surgery is going to be the last resort. So steroid injection is the first line therapy. First line therapy, and then surgery is last resort. Good. Okay. Now wound decedents. Wound decedents is that when the wound starts to come apart, basically, right? And when's it going to be seen? When's it seen? It's usually going to be seen about 7 days post-op, I believe. And what ends up happening is that the wound looks good, but in essence, you're going to have like the package is going to be full of pink salmon-colored peritoneal fluid. And treatment is that you need what you need to do is that you need to close the wound, right, with like tape. Watch your abdominal movements, and you schedule surgery to close it up again. Fifth day post-op, good. After open the peritoneum, good. Remember, it's going to be mobilization. Watch your conflict, right? Arrangements to prevent. You want to do arrangements for reoperation to prevent your ventral hernia, and also for evisceration. Evisceration is when the contents of the bowel come out of your body to like a wound, and it's going to be due because you're going to have undiagnosed wound decedents, and you're going to get up, cough, or strain. Bowel contents are going to come out. Good. Now here you need to be bedridden for a long time, 3 weeks, right? For 3 weeks, as well as good. And the bowel contents need to be soaked in saline, covered, and tight seals. Good. Covered, and then emergency abdominal closure is required. Emergency abdominal closure is required. Good. Okay. Now, acute diverticulitis and diverticular disease, which is just going to be inflammation of the GI tract in different places. If you have recurrent bowel diverticular 2 or more and you survived here, you need to have resection of the part that's affecting. Now, how to diagnose diverticular? And here you can use IV fluids, nothing per oral, and also nothing for IV fluids, and also you need antibiotics as well. As well. And then the thing about it's going to be the only inflammatory process that's going to produce left lower quadrant pain, and you're going to have fever, leukocytosis, as well as rebound tenderness and gari. Now, good. And then we said we're going to diagnose it via what? I think you diagnose it via CT. So with the CT scan. Now, if you have abdominal pain, left lower quadrant, pain is in middle age, there is a feeling of good, left lower quadrant. So the top, CT diagnostic, that's why for the antibiotics. Now, you can do CT, you need IV fluids, antibiotics, and nothing oral, which is going to cure 90% of patients. So it cures most of the patients. 90% of patients who don't cure, you're going to have some abscess. That has to be trained, percutaneous, radiological trained, right? But if the other 10% don't heal, you need emergency surgery. Good. Management of a spinal cord, remember MRI. You have your central cord syndrome, which is going to be someone who has like a rear-ended car crash, or which you have hyperextension of the neck, or extension of the neck, right? And what happens here is that burning, paralysis of upper extremities, and lower extremities and function. Now, when you have anterior cord syndrome here, this is going to be when you have a vertebral rupture, and here bilaterally you're going to have loss of proprioception, loss of pain. So you're going to have loss of pain, temperature, and you're going to have paralysis, right? Most paralyzed, loss of pain, temperature, sensation. Right? You're going to keep your vibration, and positional sense is going to be intact. Good. Okay, massive upper GI bleed. So when you have upper GI bleed, what's the cause of it, right? So cause can either be the cause of a massive upper GI bleed. What can be caused by massive upper GI bleed? Usually can be caused by like a stress ulcer. It can be seen post-op, complicated by sepsis, right? A stressful patient sepsis. And how to diagnose here is that it's going to be done by upper endoscopy. Treatment here is that you want to keep your gastric pH above 4, and what else? And yeah. So you have stressed, multiple trauma, or complicated post-op patients. So stressed patients, right? Multiple trauma or post-op patients, primary stress ulcer, endoscopy, angiographic embolization, Okay. Now, so when you have a penetrating trauma treatment, so it's going to be, so you have a couple of people, right? So penetrating trauma treatment is going to be managed expectantly. unless there are signs of what? If there are signs of your coughing up, spitting out blood, so trachea, your tracheobronchial damage, right? If you're gonna have expanding hematoma, or what else? If you have rapidly deteriorating air bug acid, right? But if it's gonna be middle of the neck, you need to have surgical expiration regardless of the symptoms. If it's gonna be the base of the neck, right, or the upper neck, right? So with the upper neck here, you're gonna have angiographic diagnosis as well as angiographic repair. It's gonna be the base of the neck here. You want to do angiographic and endoscopic testing. If it's negative, you do a barium test, right? And then you want to do your endoscopy and bronchoscopy to assess the need for surgery. Good. Gunshot wounds. So penetrating trauma treatment. All penetrating, I think. Surgical respiration in all cases. Obstructive jaundice, how to diagnose. So when you have obstructive jaundice, first off you want to do an ultrasound, right, which is going to see the common bile biliary ducts are going to be dilated, or you'll see the source of the obstruction. Good. Now following the ultrasound here, what you want to do here is that if you see like a stone, it's going to be called like gallstones, you're going to have a gallbladder full of stones, non-distended but chronically irritated gallbladder, but if it's going to be a tumor, you're going to see a thin-walled Cuvier sign, large distended gallbladder. Good. Cuvier sign, right? And following that, once you see where it is, then you want to do endoscopic retrograde cholangiopancreatic for diagnosis, followed by sphincterectomy, and eventually you're going to have your cholecystectomy to remove it. Good. Now, obstructive jaundice caused by stones. So then, when you have obstructive jaundice caused by stones, you can be American, okay? You can be Mexican American. You can be a woman, 40 years old, obese, multiple kids, and high alkaline phosphatase levels, right? And then how to manage again? You're going to do the ultrasound, and then you're going to do endoscopic retrograde. Good. Okay. Now, when you have acute hematogenous osteomyelitis, who is it seen in? So, osteomyelitis, right? This can be seen in a child who has a fever, right? A fever, and has bone pain, but clear X-rays, right? And you can diagnose it by like blood cultures, I believe, right? Treated with antibiotics, which is repair. So located fever output shows up localized pain, no history of trauma, X-ray. MRI is prompt diagnosis. So MRI is going to be prompt diagnosis. MRI, and then treat with antibiotics. Right. Now, genu varum, so genu valgus, which here you're going to have knee knocking, right? Which is normal between ages 4 and 8. Normal between no surgery needed. But then you're going to have your genu varum, which is going to be a bowed legs, which is 1 to 3 is going to be normal. After 3, you have to test for burn syndrome, which you might have this formation of the growth plate in the medial tibial tuberosity, which surgery can bring down. Good. Blount disease. Good. MRI, and then you're going to do a MRI and diagnosis, and you have to do some sort of antibiotics. Oshalt-Schalter disease. Slipped, which is going to be your slipped capital. No, Oshalt-Schalter is going to be your osteochondritis, the tibial tuberosity here. Usually teenagers who have pain on palpation of the right over the tibia. Good. Then you start off with right elevation compression, compression elevation. If that doesn't work here, you refer to a orthopedic surgeon, which in 4 to 6 weeks you're going to be in a cylinder cast. Good. Who's it seen? And then on physical exam, you're going to have pain or palpitation, right? And you're going to have and you're going to have like limb motion. And there's also going to be pain with quadriceps extension columns. There's no pain with contraction to quadriceps. Good. Okay. Now, what do we have here? Fat embolism. Fat embolism is going to come in, or someone comes in who has multiple trauma wounds, right, with multiple fractures of long bones, and fat embolism, and you're going to have this star field or what you're going to have is going to have hypoxia seen because you're going to have bilateral infiltrates on chest X-ray as well, and also you're going to have someone who has tachycardic fever and you're going to have with low platelet count, and you're going to have ecchymosis in the neck, in the back of the neck, and the auxiliaries as well. And how they occur here, to treat over here is going to be you're going to have circular support. You put on a respirator. Good. Feature measure. It's full blown blood. Proximity stuff the MRI. Remember, spontaneous revolution can occur. So before you retract, no rush to declare irreversible damage or withdraw further care. It can occur. Good. Now, amoebic abscess of the liver. Again, when you have an amoebic abscess of the liver, this can be in someone who has some sort of pyogenic liver abscess. Is going to be okay. This can be someone who has relation to Mexico, either like if you travel there, or like some sort of like immigrant, something like that. And then it's going to be men as well. And then side over here, amoebic abscess, you're going to have the liver, you're going to have fever, right? Mucositis, right? Right upper quadrant pain in the liver. And then diagnosis is going to be by amoeba. It has to be like a stool culture because no serology because the pus cannot grow in the stool. And then you want to start on metronidazole as soon as possible, right? And then if it gets worse, you want to surgery drainage. If it gets better, continue it. Good. Tender liver. Good. Ischemic process. Now, when you have an ischemic process, which causes you to have your gallbladder or like acute pain in the abdomen, this is going to be what you're going to have. What happens here is that in addition to the acute abdomen pain in the abdomen, you're also going to have blood from when you're bleeding to the gut of the lumen. So in addition, you might have like some sort of good. That's what you can see over here. In addition, the only one. Ischemic problem, like mesenteric ischemia. Affecting the bowel. So affecting the bowel, that compromised abdominal pain with blood in the lumen. Good. Now, prime peritonitis, right? It's the only. So again, prime peritonitis, you're not going to do surgery, right? You're going to treat with antibiotics, but here you're expecting in children who have ascites, right? Plus, you're going to be you're going to have someone with nephrosis and ascites, or in adults with cirrhosis, right? With ascites, as well as your mild generalized acute abdomen pain, plus fever and leukocytosis. Then the test you're going to do here is that you're going to have primary peritonitis. You're going to be infection of the peritoneal fluid, so acidic fluid. So acidic fluids are going to test a single organism, which is antibiotics, not surgery. Good. Acidic fluid. Good. Okay. Now, biliary colic. Biliary colic is going to be a temporary occlusion of the cystic duct by a gallstone, not long enough to prove you're not going to have peritoneal signs like rheumatic tenderness and guarding, no fever, no leukocytosis. Instead, you're going to have like epigastric pain. So epigastric pain. It's going to radiate to the right shoulder as well as the belt pattern of the back, and you're going to have nausea and vomiting and retching as well, with no fever, no leukocytosis as well. Now, to treat this is going to be how to diagnose here is that you're going to diagnose it via an ultrasound. You're going to nothing for oral IV fluids, nothing for oral, and anti-concussion. Good. And then anticholinergics. Good. See that? So pain in the right upper quadrant, radiating to the right shoulder. So right upper quadrant, right shoulder. Often by drinking fatty foods. No vomiting, but without peritoneal signs, right? Episodes can be limited to 20-30 minutes and can be stopped or aborted by anticholinergics. And then sonogram established diagnosis of gallbladder. Okay. Good. Now, acute diverticulitis. Now, acute diverticulitis is going to be inflammation in the GI tract, right? But the finding about here is the only inflammatory process that the acute colic have left lower quadrant pain. You're going to have left lower quadrant tenderness, fever, leukocytosis as well, and peritoneal tenderness and guarding. Now, findings is that, okay, and then understand how to diagnose here is that you're going to do a CT to diagnose it, and here you're going to do nothing per oral, IV fluids, antibiotics, and nasogastric suction. And if that doesn't work, 90% of patients, so if that doesn't work, 90% of patients are going to have abscess, so that should be percutaneous periodontal drainage. If that doesn't work, immediate appendectomy is needed. Immediate surgery is needed. And then acute cholecystitis. Now, cholecystitis is going to be a biliary colic that has lasted long enough, and the biliary colic lasted so long that you are going to develop, in addition, you're going to have fever and leukocytosis as well, and peritoneal rebound tenderness and guarding for cholecystitis. And then progression is that's going to be really cold and stay long enough. Good. Now, what you're going to have over here is that you're going to have for acute cholecystitis is that signs here, you're going to have right upper quadrant tenderness, so the pain is going to be constant. It's going to be constant. And what else you can see? And then you can do a hydro scan sometimes. Which hydro scan you're going to be in radionuclide dye. You're going to see no uptake of radionuclide in the occluded gallbladder, but you're going to see in the duodenum, in the liver, and the common bile duct. Then that comes up. It's a positive test. Treatment for here is that going to be nothing for oral fluids and all that, and then you can lead to a cholecystectomy. You want to do the cholecystectomy on the same day, and if you're cholecystectomy, and then the surgery, if you cannot have, you're going to do percutaneous transhepatic colectomy as well. So, the cholesterol remains restrictive, fever. So, liver sonograms indicated we got. Now, massive upper GI usually caused by stress altered some post-op complications. All right, here you're going to have your angiographic embolization needed, all right. And then endoscopy, and then treat your pH above 4. Okay, now lumbar herniation is going to occur where? Usually it's going to occur L4, L5, or L5S1, and that's where they're going to occur. And when about 45, 46 years old, what are the signs? Signs are going to be what? Signs are going to be, you're going to have your discogenic pain, which is pain that's going to be from stretching of the anterior spinal ligament, and you're going to have your neurogenic pain, which is pain from maxillofacial boxes. Neurogenic pain is going to be your spine, like you're down the legs and out the big toe. It's going to be L4, L5, or L5 is going to be the small toe. And also, it's going to be like disabling pain as well, and pain as well. And tests you're going to do here is you're always going to do a MRI, and that's going to be good. And then your straight leg test is going to do excruciating pain. MRI is going to be diagnostic. And treatment for this one is going to be better in about 3 weeks, where you can get like injection, like a nerve blocker to help you progress. But if you have cardiac arrest syndrome or neurological that's increasing, you need surgical repair. Good. And remember, the electron by coughing, sneezing, and defecating is going to be relative pain. You probably don't have a herniation. Good herniated disc, crazy herniated, wholly affected leg. Spontaneous resolution is the body rate of the external desk. Other things you're going to have urinary incontinence, back pain, perineal anesthesia, and fecal vagal pain. Surgery for decompression. Good. Biliary tract disease. When to suspect biliary tract disease? Biliary tract disease, when to suspect it, is that someone who has an alcoholic or someone who has recurrent gallstones, right? Urethral stones. Pain is going to be, you're going to have pain that's going to be pain with urination. It's going to radiate to either the thigh or the scrotum or labia, right? Also going to get urinary frequency and your urgency, and the cold gets into common pain. Undiagnosed here is that you're going to do a urethral stones, you're going to do a ultrasound. Good. OCT. So bilirubin should be expected when you're a fat woman. Good, and then So, well, rules of thing we're going to see using the lubrication, right? What happens here is that you're going to have some sort of intestinal obstruction that's going to cause you to have severe abdominal pain. And good. And signs over here is that you're going to have on X-ray. You're going to show. It's going to show what on X-ray is going to be. You're going to have like several dilated loops in the small bowel, and you're going to have like a enlarged air loop that's going to go from the right upper quadrant to the left upper quadrant to make a parakeet beak. Good. And then treatment for these ones is that for all people, what you're going to do is that you're going to have fluid and volume, fluid electrolyte replacement, followed by colonoscopy to remove all that free air. Then you're going to do you're going to have a like I think you're going to do you leaving the rectal tube. Then if you have recurrent balance, we're going to start the recession the same one. Good. So X-rays are used diagnostics, air fluid level, small bowel, air cycle, hair, good. And then parents B colonoscopy exam. So old people, the signs are going to be intestinal obstruction with severe downward retention. X-rays are going to be diagnostic, air fluid level, small bowel, very distended, huge air in the small in the right upper quadrant. And then you get a colonoscopy exam, overrated, rectal tube left in, recurrent. Good. Severe blunt stress to the trauma. So when you have severe blunt stress to the trauma, what can you see here? You can have the obvious injuries, vehicle for hidden injuries. So you're going to be your pulmonary contusion, geographical gases, and also chest X-rays. And also you can do aortic transection, EKG, troponin levels. Good. Myocardial contusion. Okay. Aclasia. Aclasia is going to be failure of the lower esophagus sphincter to relax, so it's going to be always tight. So here you're going to have dysphagia with drinking less liquids. So but you're going to stand up and you realize it's going to go naturally. Now signs of that can be what? Signs is going to be good, and then cause good, and then test treated. So here you go, when I want you to tell me diagnostic, it's going to be Burberry appearance. The treatment over here is going to be balloon dilation. Radiological. That's good. So X-ray shows X-rays and show megaesophagus. X-rays and show megaesophagus. Good. Biliary colic. So biliary colic again. When do they occur? They're going to occur in someone with a temporary occlusion of a cystic duct by gallstone. And signs over here is that you're going to have pain, right? Pain. That's going to you're going to have no peritoneal signs and no systemic signs of lymphadosis, but pain's going to radiate to the back, also to the nausea, vomiting, retching, into the back as well. And it's following eating like very fatty foods. And then how to diagnose here is that you're going to do the diagnosis. You're going to do a CT. And the treatment here is that you're going to have to do CT. It's absolutely going to last 20-30 minutes, in which you're going to have during by anticholinergics. You're going to do cholecystectomy, removal of the colon. That is going to be CT scan. Good. Sonic ultrasound. Good. Now, when you have biliary tract disease, you're expecting where someone who has like a 4-year-old diabetes, food pain. Here you're going to have your CT scan. Good. Okay. Fuck. Final. Holy shit. Now we have to do new ones, which I know I'm gonna mess up real bad. So we're doing, I think, we're doing breast diseases. I know I'm not gonna do that good. I'm gonna try my best. Yeah. I should have done these a couple days ago, but whatever. Today what's up to? You guys are probably gonna hate me, but these are chips, so let me mute it. So mute it real quick. And these are called protein chips, right? And they only have 140 calories in the whole bag and 5 carbohydrates, but 1 net carb because they have a lot of fiber, and yeah, they're filled with protein, 19 grams, and it's just chips. Let's watch a video on oncology. Let's see. You guys getting hungry too? I don't eat a lot of foods that have, like, the foods I eat are very, very, very low carb. I do that on purpose. But the thing is, you get hungry often when that's the case. I apologize. Let's see. video's over. Let's see. Okay, rule of thumb in all breast diseases. Regardless of the presentation of the breast mass, you always have to treat it as like you have to rule out cancer. That's what it is, right? Even in the presence of benign cancer, right? And cancer instance, like you suspect it if you have like a family history or if you have some sort of like family history, right? Another one is that if you have increased age. Good. The only way to rule out cancer is going to be a biopsy, a tissue biopsy. Good. Now, women at risk, no. Now, mammogram. When we talk about mammogram, what is it? It's going to be like a modified x-ray. And why is it useful? In that it can show you to have any sort of breast masses that are not show up in physical exams. When did they begin? They begin at age 40 in the New York, right? Now, they're not going to be done. Mammograms are not done in women who are 20 years old or younger because of the dense tissue, or if you're lactating, because it's just going to be milk. Exceptions that if you are pregnant and you have breast cancer, you can get a mammogram. That's going to be fun. That's going to be fine. How to rule out is going to be either a core biopsy, a core or incisional biopsy. That's the way that I know. Good. Now, so how to rule out cancer is going to be a mammographic ultrasound core biopsy. Good. Then good. Now let's see. Now, for early if you have a family history. Now, women. So if you have a BRCA1, BRCA2 gene, right? Just so you know that indications is that screening for breast cancer is you need for early and you need for frequent breast screening but you're not going to do your recurrent mammograms. You're going to do MRI because it's going to be cardiogenic if you do recurrent mammograms. Good. Now, prevention from this one. If you have a BRCA2 mutation here, you're going to do. Look at this, guys. One second. One second, guys. If you have a BRCA2 mutation, you do a bilateral mastectomy. If you have a BRCA1 mutation, you do bilateral mastectomy plus oophorectomy. Guys, it seems like our study session's over right now. We did about 2 hours and 30 minutes on a stake. I thought it was 2 hours. I got a couple things I got to study. I still have to finish my review of the new stuff I just learned. Breast cancer, then I have to do chapters 6, 7, and 8. I don't like to make these videos too long, but I think I'll end it here. If you want to study with me a little longer, just replay the video. If not, best of luck. I hope you got all your studying done. I hope you're very productive. Let me know in the comments how can I improve these videos, anything you want to see me do differently, things that you liked that I did, things that you didn't like that I did. Yeah, because I want to keep this going because I enjoy studying, and it's like I kill two birds with one stone because I get to make a video and I get to do studying done. So yeah, and also let me know what you're studying. I want to know if you guys are in medical school, if you guys are high school students, if you guys are college students, if you guys are engineering students. I want to know that stuff, okay? So anyway, it's been a pleasure, guys. Hope to see you guys soon again. If you guys liked the video, give it a like, comment, subscribe, and see you again next time.